Good day. My name is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology, and I'd like to welcome you to our Wednesday webinar series entitled Medical and Public Health Considerations of COVID-19. Next slide, please. I'd like to thank our webinar series partners. Next slide. I'd like to remind everyone that these webinars are recorded and will be posted on the ACMT website within 48 hours of the presentation today. We also have a variety of resources on our website, and any specific questions about the about this webinar series can be directed to info@acmt.net. We recently updated our FAQ section on PPE. This just went live this morning, and I invite folks to check out the questions, which have all been peer reviewed to find out the latest about PPE. Next slide. We have two presentations today. At the end of the second presentation, we'll open up to Q&A. Please type in your questions either into the Q&A box or the chat function box. And for those who are watching on either YouTube or Facebook Live, you can chat in your questions on those two devices as well. Next slide. There are no conflicts of interest. Next slide. At this point, I'd like to turn over the introductions to my colleague and partner, Dr. Ziad Kazi. Dr. Kazi is a board member of the American College of Medical Toxicology, president of the Middle Eastern North American Clinical Toxicology Association, and associate professor of emergency medicine and medical toxicology at Emory University. Dr. Kazi.
Thank you, Dr. Wax, and welcome everyone to this webinar. It's a really important topic that we are discussing today regarding the mental health aspects of this pandemic. I believe that we are all experiencing to varying degrees some mental health stress, and I could not think of anyone better than Dr. Nadine Kaslow, who is currently a professor of psychiatry and psychology at Emory University. She's also the past president of the American Psychological Association and has been deeply involved on a day-to-day basis in responding to the mental health needs of our community here in Atlanta. So she will be discussing building psychological resilience during COVID-19 and beyond. Dr. Kaslow?
Thank you very much, and I'm happy to be here with you today to present.
Thank you, and you sound very, very good.
Okay, great, thanks. All right, so I want to start out a little bit by talking about some of the psychological impact that COVID-19 has had on healthcare workers, which are many people here today, and then also what we can do to be resilient in the face of these impacts. So there's been tremendous stress on healthcare workers. We are facing limited access to childcare with our children at home, not necessarily enough. We're not very good at teaching our kids. I think we have a greater appreciation for teachers these days. Many healthcare workers are saying that their partners just don't get what they're going through, and so they're not feeling supported enough by their partners. They're also very worried about going home to family and infecting them because of the exposure that we have each day at work. But healthcare workers have complained about many other things or expressed concerns about many other things that are major stressors for them. One thing is that many people are in systems where the leadership has not been as effective as would be optimal in terms of communicating. And so the messages we get are not necessarily clear, consistent, transparent. And this was really a major problem at the beginning of the epidemic. And now as sort of things ramp back up, it's starting to be more of a problem again. But this has been very confusing and stressful for people. I saw that there were the slides on PPE and lots of answers to questions about PPE. And I think there's limited resources to be able to do the kinds of things we need. And what might be okay in terms of PPE might not be PPE that really makes people feel safe. In addition, we don't have enough human resources to do all the work we need to do. And of course, there's tremendous exposure to COVID-19 while we're in the workplace. What are the other stresses? Well, psychological stressors were the added demands that people are having to deal with. The long hours, being asked to practice beyond the bounds of our competence, being deployed to unfamiliar services, and of course, having to watch people who are really sick, ill, who are dying. And often it's the healthcare workers who are in their rooms and serving essentially as family during this time for people. We've heard stories nationally and globally about people getting fired, healthcare workers getting fired or getting in trouble if they speak out. Some people, while many communities are really honoring healthcare workers, in other situations, healthcare workers are feeling abused in their community, often feeling like they can't trust the organizations that they work in. We've talked for years about burnout, but we're really seeing burnout up close and personal every day, and it's growing and it's growing and it's growing. And the burnout is coming with people feeling more anxious, more depressed, and having more mental health problems. We're certainly hearing about increased rates of suicidal behavior, including death by suicide in healthcare workers. And of course, one of the major stressors is healthcare workers are very worried about getting sick or dying themselves. One of the major reactions, there's lots of psychological symptoms people are having, but for the sake of time, I just want to focus on a few. One reaction that has really been dominant among healthcare workers during this time has been guilt. Lots of reasons people are feeling guilty. They have survivor guilt. I'm alive, somebody else isn't. I'm able to do the kind of job I know how to do. Somebody else is being deployed elsewhere. Healthcare workers are guilty when they're at work. I'm afraid I'm going to get infected or infect other people. But they're also guilty when they're not at work. It's like we can't win as healthcare workers. And there's tremendous guilt among the moral distress that people are feeling as we're all having to encounter making decisions that are really ethically very, very complicated. Whether that's who gets access to ventilators or how long a code is run, or things like whether or not family can be at the bedside. These are very challenging decisions that bring us a lot of distress. Let's see. In addition to feeling a lot of guilt, we're also experiencing a tremendous amount of grief. There's more patient deaths than people are often used to handling. And it's very hard for patients to be dying alone. Families are not able to be with their loved one. And we're witnessing high rates of illness and death in our colleagues. As I mentioned before, one of the things that's been most concerning are the rates of suicidal behavior. Well, we don't exactly know how much increase there has been in suicidal behavior in healthcare workers or in the general public. We do know that there are anecdotal reports of increases in suicidal behavior. So, for example, in one day, two healthcare workers, a nurse in Italy and another nurse in the UK, died by suicide on the same day. In April, just a few weeks ago in the US, there was a New York Times article that reported the death by suicide of an ER physician. And all of these deaths just sort of have people reeling. Why are we experiencing such increased rates of death by suicide? Well, healthcare workers in general, at baseline, are at increased risk for suicidal behavior. And so this is no exception. But they're also really overwhelmed at this time. There's a lot of trauma that we're experiencing associated with the horrors of these deaths. People are feeling helpless, they're feeling powerless, they're feeling hopeless, and they're afraid of infecting other people. There's also, we have high rates of psychological symptoms, and the reports I'm going to give right now are from China, and we're just beginning to see the rates in the US. It seems like my slides are over to the side a little bit here and cutting off one side. Can we extend this a little bit on the right side?
They actually look pretty good, Dr. Kaslow.
So they look okay to you?
Yeah.
Okay.
Yes.
Okay. All right. So as you can see, these are rates from China of healthcare workers. And we have quite high rates of symptoms of depression, of anxiety, problems sleeping or insomnia, and just overall distress. And we're beginning to get similar rates from healthcare workers in other countries. In China, the most severe symptoms were in nurses, and that's largely because they're often the ones at the bedside the most. Women, again, they're often at the bedside. Frontline workers, people who are younger and I think have had less experience dealing with trauma in the workplace. And of course, those in Wuhan. And I think what the equivalent to that would be is whatever country we're in, whatever our epicenter is. So in the States, that would be New York. I think we're going to expect to see higher symptoms. When they compared in China the rates of psychological problems in healthcare workers to non-healthcare workers, we saw that healthcare workers have more problems sleeping, more anxiety, more depression, more somatic symptoms like physical symptoms, often wondering, well, do I have COVID? And more obsessive compulsive symptoms like being not just washing our hands the way we're supposed to, but sort of rigidly and obsessively doing things like that. So in light of all these stresses and all the psychological challenges that we are having to deal with, how can we be resilient? What can we do to be resilient, to grow, and to make meaning in light of this pandemic? The COVID-19 pandemic is a collective trauma. It's not my trauma or your trauma. It's one that we're all experiencing together. And as a result, it means that we're all having to deal with our own mortality, as well as in the mortality of people that we love. It's placing us at a crossroads as individuals, as communities, as cultures, and as the world of humans all together. And we need to decide how we're going to respond. So there are a number of things that we can do to optimize our response, to respond as well as we possibly can. Three of the main things, and I'll talk about each one of these a little bit more. One is to be resilient, and I'll talk about that. Growing in response to the trauma, or what's called post-traumatic growth. And finally, finding purpose and finding meaning. So what does it mean to be resilient? Well, it's having to adapt. It's us adapting in the face of adversity and trauma and tragedy and threats and sources of stress, all of which we're experiencing right now with COVID-19. Being resilient means using a range of coping strategies. What works well for me might be different than what works for somebody else. So this is not a one-size-fits-all coping strategy, but rather we each need to find our own strategies, and not just one, but multiple coping strategies. We need to remind ourselves and be sure that these are difficult experiences, but that we need to do our best to bounce back from them and see what's the good in things and maintain our hope. That we need to really be invested in personal growth and professional growth in the face of these situations. One of the things I started doing, for example, is writing down each day what I've learned. And I've learned a tremendous amount during this time, and really having a sense of how can I grow and how can I expand my horizons. And that's doing that in spite of or because of the pain and the distress that we're feeling. Growing from the trauma or what's called post-traumatic growth means that we make real shifts in our thinking related to ourselves and related to other people or the world that influence how we deal with adversity. And what happens is we really make these shifts. So we prioritize, say, things differently, or we get really clear about our values, and we make choices that are driven by these values. Then we have a higher level of functioning, and we have a lot more strength. So to grow from this pandemic, we need to embrace learning. No, it's stressful, all these new things that we're having to deal with and learn, but we need to embrace them. Find ways to adapt, creative ways. Many people are finding remarkably creative ways as we all go to weddings. Going to a virtual wedding this week, for example, or been to more than one virtual funeral, unfortunately, during this time, and finding ways to adapt and change. Rising to new challenges as they emerge, and really noticing that it's not just our formal leaders that are rising to these challenges, but new leaders among us and many, many people really finding wonderfully creative and important ways to rise to these challenges. And recognizing the sort of strength that we have inside ourselves, maybe strength that we didn't know we had, or courage or fortitude, and really capitalizing on this. It's imperative that we be creative, we use humor. And I ask when I go to the hospital and talk to teams on the front line about what they're doing to cope, one of the first things teams often tell me is about the sense of humor that they have. And they're finding creative ways to cope. For example, one unit, they're doing what they're calling 30, 30, 40, or 100 squats each shift. They do 30 at the beginning of the shift altogether, 30 in the middle, and 40 at the end. And wouldn't you know it, but everybody's getting stronger and more able to do that. And I just love the picture of this woman. It's an older woman, and we know they're at great risk for the COVID-19. And it says, trying to flatten my own curve, as she sort of has a sense of humor while she's exercising. And rebuilding our communities so that they're stronger and that they're more connected. So many people talk about, I've really gotten to know my neighbors. I'm seeing my neighbors more. I know who they are. And really taking the time to really rebuild our communities. And then it's really about making meaning. Everybody's probably learned from Kubler-Ross the stages of the grief process. And recently, last year, actually, Kaslow published a book called Meaning Making. And that really has to do with the final stage in the grief process, which is necessary for healing. And by making meaning, we really feel healthier, more energetic, more productive. It gives us greater values to guide what we do. It helps us feel better about ourselves and more in control. And it really enriches us and helps us feel part of a larger community. Meaning making right now during this time for sure means exercising responsibility to look after our own health and the health of other people, to commit to a we culture. It's a culture that we're all in it together. His Holiness the Dalai Lama just gave a wonderful, just wrote a wonderful statement, I thought, that Desmond Tutu read. And it really talks about unity, and that this is a time for us to unify and have a we culture, because we are all indeed in it together. And of course, we need to grieve what has been lost, not just the people that we've lost who have died, but the sense of normalcy that we've lost, the economic stability that we've lost, all the other things that we have lost. We also need to pursue meaning and hope, taking this time to take care of ourselves and other people. As healthcare professionals, we're really good at taking care of other people. We don't get as high marks in taking care of ourselves. We need to find some solace in these new forms of connecting, new ways of interacting that we didn't have before. And again, being creative as we socially connect. It's really important that we cultivate a sense of hope, even when things seem so hopeless at times. But hope that we can get through this difficult time and that we'll be strengthened by it, that we can each grow through this pain, and that it's really important every day for us to appreciate the small things in life, the weather, the trees that maybe we never saw before because we weren't home during the day. We need to, it really helps to remember other times in our lives that were challenging and how we got through those, what we did to be resilient. We've all had difficult times in our own lives in the past, and we did things that helped us get through those times. And of course, we have to nourish our social support, our relationships with our friends, our family, and our colleagues. We need to nourish those, and we need to appreciate the support that we get from other people. I think it is imperative that as healers, we really focus on being compassionate. And I know it's so hard right now as people are bundling orders to be in rooms for short periods of time and things like that. There are all sorts of ways that we can and must hold on to that compassion towards other people and towards our patients. And the more that we can do that, the better off we are all going to be. And so I want to make a few comments in closing. The first is from Brene Brown as we think about moving forward. and I'm not sure I'm going to be able to read this whole slide. Let me just see. Okay. We will not go back to normal. Normal never was. Our pre-corona existence was not normal, other than we normalized greed, inequity, exhaustion, depletion, extraction, disconnection, confusion, rage, hoarding, hate, and lack. We should not long to return, my friends. We are being given opportunity to stitch a new garment, one that fits all humanity and nature. And I think that this is so very true. We can't go back to normal. We have to go forward to a new normal. And to do this, we need to capitalize on our strengths, to optimize our own ability to cope, grow from this pandemic in as many different ways as we can, engage in meaning making both personally and professionally, because there's so much we can't control about this virus and the dark times associated with it, and meaning making can really help us make a difference. We need to ask ourselves, what do I want to be during this pandemic and beyond? Do I want to stay in the fear zone where practically all of us were at the beginning? Do I want to shift into the learning zone, which hopefully many of us are in? Or do I want to be in the growth zone, where, again, hopefully we are beginning to move so that we really can focus on not just learning, but growing? I want to take this opportunity to acknowledge my colleagues in the caring communities. We've been working together to care for COVID caregivers, and I want to express my care and sense of connection to each of you during this pandemic. Thank you very much.
Thank you, Dr. Kaslow. It was a very inspiring presentation, and I identified personally with many of your points that you shared with us. Thank you. Please type your questions right now, the rest of the presentation, and we will address them at the end. With this, I'll turn it over to Dr. Paul Wax, Executive Director of ACMT and Past President of ACMT. Dr. Wax?
Yeah, thank you, Dr. Kazi, and again, thank you, Dr. Kaslow, for a really a wonderful presentation. Next slide, please. I'd like to introduce our next speaker. Kenneth Mead is the Chief Engineering and Physical Hazards Branch Division of the Field Studies of Engineering at NIOSH, which is part of CDC. And he's going to give us a very timely talk on the control of infectious aerosols using air exchange, filtration, and source control. Dr. Mead does not have a full slide deck for us, but we'll be using a couple slides as background reference material. Thank you, Dr. Mead.
Thank you, Dr. Wax. Can you hear me okay?
Yes, very good, thanks.
Thank you. I'd like to start out my talk today by pointing out a disclaimer that should be loading up on the screen here shortly. My intent today is not to contradict any guidance coming from my employer, and so if I mistakenly do so, please realize that this is my mistake and it's not a breaking announcement of changing CDC guidance. The other point I'd like to make is to remind everyone that I'm an engineer, not a clinician. I'll try to be accurate in my use of clinical terminology, but if I make a mistake, I'm seeking your forgiveness up front. Today's talk is being delivered without slides. However, I've provided a list of U.S. government websites that I'll refer to as I progress through today's conversation. It's my understanding that a PDF of this slide will be made available after today's webinar, and interested individuals can use that to delve in more deeply. I encourage anyone who is interested to delve deeply into those websites. There's a ton of information there and is being updated constantly. The first internet link is coronavirus.gov. It's somewhat of a one-stop informational gateway for government guidance related to COVID-19. If you scroll about halfway down that webpage, you'll see a link for specific resources for healthcare professionals, which subsequently takes you to the CDC webpage on that topic. And then if you dig in a little deeper and you click on the infection control link button a couple times, you'll eventually get to a document entitled Interim Infection Prevention and Control Recommendations for Patients with Suspected or Confirmed COVID-19 in Healthcare Settings. In this document, we can find information on lots of IPC topics, including CDC's prevailing thoughts regarding transmission, as well as the minimum guidance for placement of patients suspected or confirmed to have COVID-19. In regards to transmission, the virus that causes COVID-19 is thought to be spread primarily through respiratory droplets when the infected person coughs, sneezes, or coughs. Airborne transmission from person to person over long distances is unlikely. However, COVID-19 is a new disease, and we're still learning about how it spreads and the severity of illness that it causes. The virus has been shown to persist in aerosols for hours and on some surfaces for days under laboratory conditions. There are also indications that patients may be able to spread the virus while pre-symptomatic or asymptomatic. For patient placement, if hospitalization is not medically necessary, home care is preferable if the situation allows. If admitted, place a patient with known or suspected COVID-19 in a single patient room with the door closed, and the patient should preferably have a dedicated bathroom. If multiple patient rooms are unavoidable, then there's only patients with the same respiratory pathogen should be housed in the same room. With regards to COVID, we're basically saying it's ideal not to cohort suspect cases, or if you have identified cases as confirmed positive, then it's okay to cohort those cases. Airborne infection isolation rooms should be reserved for patients who will be undergoing aerosol generated procedures. And by that, we're talking about things like intubations, extubations, some forms of non-invasive ventilation. Airborne infection isolation rooms are single patient, negative pressure rooms with a minimum of 6 air changes per hour. However, new construction and renovation should have had 12 air changes per hour. And that's been the rule since about the mid-90s. So in most cases, we should be looking at 12 air changes per hour or greater. Air from these rooms should be exhausted directly to the outside or be filtered through a high-efficiency particulate air filter, HEPA filter, directly before being recirculated. By definition, a HEPA filter is 99.97% efficient at removing airborne particulates at a size of 0.3 micrometers. This does not mean, and this is contrary to what you might read on the internet, this does not mean that HEPAs are ineffective at other particle size. Rather, the 0.3 micron particle size represents the most penetrating particle size, and the filter is even more efficient at sizes smaller and larger than 0.3 microns. Once the patient has been discharged or transferred, room reentry should be avoided, and this includes the environmental services personnel, until sufficient time has elapsed for enough air changes to remove potentially infectious particles. And I'm going to discuss the clearance rates in more detail shortly. After this time has elapsed,
Dr. Mead, sorry do you mind speaking up just a little bit? I'm sorry to interrupt you.
Okay.
That's better. Thank you.
Good. Yeah. After this time has elapsed, the room should undergo appropriate cleaning and surface disinfection before it is continued to routine use. The next web link takes us to something called the hierarchy of controls. The hierarchy of controls is one of the primary tenets in the field of occupational safety and health. And as you can see, it is shaped like an inverted pyramid. Can you go ahead and slide down a tiny bit on that screen a little bit? It looks like the pyramid's cut off. Thank you very much. As you can see, it's shaped like an inverted pyramid, and within the pyramid is a prioritized list of control intervention concepts listed in preferential order from top to bottom. Of particular interest to this audience may be the position of personal protective equipment, or PPE, which is at the bottom of the inverted pyramid. While the impulse is often to reach first for PPE when considering how to address a potential exposure scenario, when sufficient time allows to anticipate and plan on how to deal with that scenario, one of the higher up control methods is often a preferred and more protective response. At times, important to note that more than one control method is required in order to provide adequate protection. But let's talk through the hierarchy of controls a moment and think about particular examples related to the COVID response. Preferred control concept of elimination, examples of that would include things like conducting triage prior to the front door entry of the healthcare facility, where potentially infectious patients might be pre-identified, provided a face mask for source control, routed through a special entry door, or even sent home for home care if it's clinically appropriate. The next concept, substitution, well, in industry or manufacturing industry, this will include things like substituting a safer chemical, say a safer cleaning solvent in place of one that might be more toxic. This one does not really fit well in terms of the COVID response, or at least I cannot think of an example. For engineering controls, which of course is a topic near and dear to my heart, we're talking about eliminating or reducing the exposure from the working environment You do so generally without much involvement of the workers themselves. Engineering controls are often targeted at the source point of generation before it becomes an issue. Examples include local exhaust ventilation, induction booths, even airborne infection isolation rooms. Specific to the COVID response, engineering control concepts in the public discussion include such things as the intubation boxes you may have seen discussed on TV or the internet, the ventilated headboard, which we'll discuss later, or clear barriers that are installed to protect reception desk attendants. Administrative controls are rules intended to protect workers from or limit their exposure to a potential hazard. Specific examples might include intentional placement of healthcare workers with high-risk conditions to work in wards where COVID-positive patients are not expected. Another example is the designation of COVID treatment teams, which thus limit the number of healthcare workers who will work with suspected or confirmed COVID-positive cases. The final category is personal protective equipment, and that's the lowest preferred control. It is most applicable to scenarios where other controls are insufficient, unavailable, or they're still under development. Examples include respirators, eye protection, protective gown, gloves, shoe covers, and hair bonnets. The next link takes us to an online presentation that discusses the behavior of aerosols. The presentation was developed by the late Dr. Paul Baring. Paul was a brilliant aerosol scientist that retired from CDC NIOSH several years ago. And if we progress down to slide 12 of that presentation, which is what's on the screen now, you'll see a chart of different aerosol sizes and the time it takes for them to settle to the ground if they were released at approximate breathing zone height of 5 feet. Now, most of you are probably aware that in the clinical world, the dividing line between the terms aerosol and droplet is generally considered to be 5 microns. When this was originally defined, this likely had to do as much with thoughts on lung penetration as it did aerosol behavior. However, you can see from Paul's slide that a clinically defined droplet, one that's as large as 10 microns, will still take a few minutes to fall to the floor. If this occurs in the presence of a room air current, you can imagine that this 10 micron droplet might get carried a little ways before eventually landing or impacting on some other surface. Does this mean that the droplet could generate airborne transmission? Maybe, but not necessarily. It partially depends on how much it shrank while it was in the air. The original 10 micron droplet would be too large to really get deep into the lungs. Smaller droplets, sometimes called droplet nuclei, less than 5 microns, might get deeper into the lungs, but even then, they may not still have sufficient virulence to transmit disease. And since the air concentration of droplet nuclei is diluting the farther we get from the source, there may not be enough airborne droplet nuclei to breathe in at any point in time to result in an infectious airborne dose. And a reminder on that concept is, of course, the infectious dose requires both sufficient concentration of exposure as well as sufficient time within that concentration. While there's still a lot to learn about coronavirus that causes COVID-19, the EPI reports to date seem to indicate that while shorter range aerosol transmission may be occurring under certain circumstances, and generally those are ones where you might have a longer duration exposure, long range airborne transmission is not thought to be occurring. The other important takeaway from the droplet scenario we just discussed is to remember that surface contamination can be more of a cumulative buildup. It's not reliant upon that point in time concentration. Thus, even if the airborne concentration was insufficient to cause airborne disease transmission, it is plausible that the concentration could build up on a surface over time, eventually become insufficient for an indirect contact exposure. Thus, the prevalence of guidance about hand washing, not touching your face, and disinfecting frequent touch points makes good sense. Link number 4 takes us to a chart in CDC's infection control guidelines that delineates the time required to purge a contaminant to 99% or 99.9% for a given infection rate, specified as air changes per hour. One way to envision the concept of air changes per hour is to take 2 identical clear water glasses, fill one with water and the second with a dark or bright colored fluid. If I take the glass of water and pour it into the glass of colored fluid, that represents one change of glass volume. And for the purpose of the exercise, we'll call it an air change for this example. Obviously, you want to do this experiment outdoors or over a sink. If you then pour a second glass of water into the now diluted colored liquid, that represents a second air change. You'll notice that with each successive air change, the colored fluid gets lighter and lighter in color After a few air changes, the colored glass water may look pretty clear, but there will still be small amounts of the original colored water remaining. Now that we understand the concept of air changes, let's look back at the table. Pretend we have an airborne infection isolation room with 12 air changes per hour. Our potentially infectious patient just left the room, and we want to wait until any airborne pathogens have diminished by 99%, which is a common reentry target for healthcare. Looking at the chart, at the intersection between 12 air changes per hour and 99% shows wait 23 minutes. But hold on a second. What is often overlooked with this chart is that it represents perfect mixing, which almost never occurs. If we were to scroll down and read all the footnotes, we find that the 23-minute time on the table needs to be multiplied by a mixing factor, which is an indicator of how well the HVAC system ventilates the room. For good mixing, which is probably a good assumption for most airborne infection isolation, a K factor of 3 is appropriate, and the 23 minutes should be multiplied by 3 to get 69 minutes. If the room were a bedroom with an air change per hour of 2 and a core mixing efficiency of, say, 8, the 99% reduction wait time would be 138 minutes times the K factor 8 was 1,104 minutes, or almost 18 and a half hours. Hopefully this example demonstrates why airborne infection isolation rooms require a higher air change per hour ventilation rate. Sometimes when an airborne infection isolation room is not available, or it's an older room with only 6 air changes per hour, healthcare facilities might use a portable air cleaning machine with HEPA filter to create additional equivalent air changes and faster aerosol reduction. In my next discussion topic, I will discuss how to combine a strategic air inlet design with such an air cleaning device to create even faster air cleaning and shorter turnover requirements. The next topic is source control. I mentioned earlier that the face mask can be considered a form of source control, although it also requires a fair amount of cooperation by the wearer, and thus is not really source control in the engineering control sense. Link number 5 discusses an example of source control using engineering design methods. This link takes us to a NIOSH blog site that describes an engineering control intervention for the control of potentially infectious patient-sourced aerosols. The intervention is called the ventilated headboard. Additional links on the blog page can take the reader to other supporting documentation, the supporting research on how the headboard was developed, different ways in which it can be applied. There's even a video that describes how the source control method works. The ventilated headboard intervention is not a filtration system in itself. Rather, it is a special inlet system designed to provide a strategically improved air intake for corresponding HEPA fan and filter unit. Together, the ventilated headboard and HEPA system can provide multiple isolation units or surge isolation capacity in a variety of traditional and alternate care site scenarios. The ventilated headboard design provides near instant capture of patient-generated aerosol. After performing the air changes per hour experiment we discussed above, one can see the benefit using engineered direct source controls that can capture and remove aerosols almost instantly. Such interventions significantly reduce room turnover times, while also reducing the additional risks that might be associated with extended use and reuse of personal protective equipment. The sixth and final link I want to share today is a link to something called the Master Question List. And it's from the Department of Homeland Security's Science and Technology Directorate. This site is updated approximately weekly and includes 2 general components. There's something called the Master Question List, which quickly presents the current state-of-the-art or state-of-the-available scientific information on fundamental questions such as what is the infectious dose, or how long does the virus persist in the environment. The second part is a summary table that discusses relevant topics from the perspective of what is known, what additional information do we still need, and who might be researching the topic. Collectively, given the rate at which information is being published on COVID-19, the Master Question List is a very valuable time saver for those of us who try to stay abreast. For those who may be interested, I also listed 2 non-governmental websites that are at the bottom of the page there. And those websites are developed by engineering associations who specialize in engineering controls and healthcare facility design. Both groups have published COVID-specific resources that healthcare facility engineers and others may find useful. Please note that no CDC endorsement is applied by my sharing these links. I thank you for your time, and this concludes my prepared discussion on this topic.
Yeah, thank you very much, Dr. Mead, for a very interesting presentation, which has tremendous relevance to all of us. At this point, we will open up the Q&A session. We have about 20 minutes or so. So please type in your questions either into the chat function or into the Q&A function on the WebEx, or if you're on YouTube, you can chat in questions in the chat function on YouTube. Dr. Ziad, Kaslow, and myself will trade off asking some of the questions. The first question is to Dr. Mead. What does the term airborne mean? Is this a category between a droplet and an aerosol?
So it depends on the audience you're referring to. Airborne, in a clinical sense, means that it's been identified as a disease that can be transmitted through deep lung penetration. It's generally thought to occur with infectious aerosol that are less than 5 micron in diameter, and then the site of onset will be that deep lung penetration part.
Okay, question is for Dr. Mead as well. Can you comment on a recent JAMA publication supporting a face shield versus a face mask?
I cannot comment on that. No, I don't. I'm not familiar with it. I could see where that would be plausible, that a face shield that does a better job of covering the face, and if we're talking about source control, at least in terms of direct person-to-person generation, that might be more effective. However, knowing that the face shield is open on the sides, my instinct is to say that if I'm coughing or generate source aerosol, that a lot of that source aerosol is still going to escape the sides of the face shield more easily than it would a mask.
Okay, great, thank you. Next question, how should a HVAC filter be handled? There has been some suggestions that there are disinfection procedures for these filters. Any comment on that?
So that's going to depend really on the scenario. If you have reason to believe that there was potential exposure to coronavirus particulate in the airstream, then certainly if you have the capacity or the capability to get in upstream of that filter and treat it, and then give a sufficient wait time before removal, then there's certainly nothing wrong with that approach. Of course, if you're going to spray it with an EPA-approved disinfectant for coronavirus, you're going to want to make sure that your disinfecting process doesn't aerosolize things. So you're not going to take a compressed aerosol can and hold it right up against the surface of the filter. That being said, additionally, if you knew that it was potentially exposed to coronavirus aerosol, at this point in time, it still seems like it would be prudent to go ahead and use an N95 respirator as well as gloves. Having said that, however, I have to say that's my personal opinion, as well as that as a lot of people in the industry. I don't know that guidance has particularly been published by CDC.
Okay, great, thank you. Another question is about how long would you proceed with another endoscopy in a non-negative air pressure room? I think that's to say that if you're doing endoscopy procedures in a room that is not negative pressure, how long would you have to wait between procedures?
I guess part of that answer is going to depend on whether or not the person receiving the endoscopy was a suspected or confirmed COVID patient. So that's going to drive my equation. Even if it's not an airborne infection isolation room, you should still be able to ascertain what the ventilation rate in that room is. It might not be a bad idea going forward if you have the ability to even augment that ventilation rate with portable filtration, like I mentioned before as well during the discussion. So at that point, then it becomes an infection control risk assessment perspective if it's not a COVID positive patient, and so I would think that decision is going to be made based on the infection rate in your community and things like that. If it is a COVID positive patient or a suspected patient, and you identify your ventilation rate in the room, including anything that might be augmented with HEPA, then you could look at that chart that I referred to in the presentation and help determine what a appropriate wait time would be.
Okay, great, thank you. Another question is about ventilation in school buildings and whether there is any potential concern about virus transmission due to the standard ventilation in a school building.
I think the predominant factor in that is really going to be on what the prevailing case rate is in the community. My area of expertise really is more in terms of the healthcare environments, and so I'm going to play it safe and not comment on school ventilation on this one.
Okay, that's great. Thank you. Well, speaking of the healthcare environment, can you address aerosols in a dental office setting?
I can. So again, it's going to depend as well whether or not you have reason to believe that your patients are COVID positive or suspected COVID positive. If you have no reason to believe that's the case, then again, you're going to make decisions based on prevalence that's occurring in your community. I happen to know that CDC is in the process of developing some guidance for dental practice that should be getting published fairly soon, and hopefully that will be helpful in giving a concrete answer. Generally speaking, though, it's going to be the same things that we talked about earlier, which is you can augment your ventilation rate using things like portable HEPA filtration. There are some auxiliary dental techniques using a high volume extraction and things like that, and dental dams, which might help. You can, if it's an open bay area, you could potentially add barriers, and preferably ones that are easy to clean between your, I'm not sure what they're called in dental, the stalls or whatever the working areas for the dental activities. And then there are things about the placement of the patient themselves. Is it better to put their head closer towards the corridor everybody's walking by, or should we turn those chairs around and have them be more towards the back wall? And that way, if I put a HEPA filter there in that area, I'm trying to ventilate and filter a smaller area, and we'll have a better control.
Okay, next question, reflecting the diversity of folks we have on this webinar, is about operating rooms and air exchanges. And as you commented before about endoscopy suites, any variation in your advice about air exchanges in an operating room setting?
No, operating rooms really already have a pretty high airflow rate. I believe it's 20 air changes per hour is prescribed. And so going back to my statement earlier about the ability to receive an infectious dose requires both the concentration and the time in that high concentration. Such a high air change rate in an operating room really reduces that likelihood significantly. One thing I have heard concerned is operating rooms tend to be under positive pressure. And so there was concern about, does the positive pressure of that operating room potentially push contaminant outside of the OR? And this could theoretically be a concern if it was a known COVID positive case, especially depending on what procedures were going on in the OR. If that was a concern, there are these portable anti-rooms, which are negative pressure anti-rooms, which could potentially be installed on the outside of the operating room. And so they would be out of the OR environment, but yet anything that might be escaping out the doors, they could capture that. Of course, it would be important to double check the construction and the development of that to make sure you're not going to interfere with any ingress or egress of the OR.
Okay, thank you. Could you also comment again about the difference between droplet spread and aerosol spread, and the likelihood of potential infectivity of droplet spread versus aerosol spread?
So right now, the prevailing thought is that almost everything that's happening is either direct contact, direct patient contact, or droplet within close proximity of the patient. There is a potential that we could have some aerosol transmission occurring. That's predominantly, again, because of that whole dose concentration thing I talked about earlier. It's probably happening only within a relatively close range of the source as well. There's been nothing that I'm aware of in the epi literature that's been coming in from around the world that has identified any term of really long range kind of transmission, like through an HVAC system or anything like that.
Okay, thank you. I think I'll turn it over to Dr. Kazi. There were several questions for Dr. Kaslow, and there are also some additional questions in the queue for Dr. Mead.
Thank you, Dr. Wax. Dr. Mead, I think we've been bombarding you with questions. I'm going to give you a few minutes break and get back to you. I have a couple more questions for you. I want to turn it over to Dr. Kaslow. If you don't mind, I'm muting Dr. Kaslow, and Dr. Mead can mute in the meantime. I have a couple of questions that came through here that are interesting. One of them is about the prevalence or incidence of these mental health, manifestations of mental health illness in Wuhan. To comment on the Wuhan experience, any of the data is available. And the second question that was related asks about the comparison between this pandemic and other disasters. Do you think that there'll be more health impact or less, similar?
Right. So the rates in Wuhan are actually pretty high, with distress rates of over 70% and depression and anxiety in the 30-40% range. That's significant levels, not just I feel a little sad. And the initial data that are coming out from sort of some studies in the US and in other countries are showing very similar rates. When we look at prior pandemics, the rates seem to be a little lower than we're seeing right now. And I think it's because maybe so many people are affected in so many different ways, but it seems like we're seeing somewhat higher rates right now, which is very concerning.
And a follow-up question on that, if you can elaborate upon PTSD, sleep disorders, and increased substance use disorders among healthcare professionals.
Yes, absolutely. So, there's been a lot of talk about sort of acute stress disorders that people are feeling right now, and being concerned that a lot of this is going to turn into post-traumatic stress disorder. And the difference between the two of those has to do with how long it lasts after the trauma is over. And because the trauma is ongoing right now, it's just hard to know what rates of actual post-traumatic stress disorder are going to be. I think it's really important that we not pathologize individual healthcare workers and give them a psychiatric diagnosis when really it's a commonly experienced problem right now. And we need to treat it as sort of something we're all feeling and it's normal. And only if it really persists for a long period of time or gets in our way of functioning do we need to sort of label it and treat it in that way. In terms of sleep, so we're seeing from the beginning, in all the support groups we've been running, problem sleeping has been the number one thing, one of the first things people have complained about. Whether or not it's a diagnosable sleep disorder is another matter, but people are just having symptoms of sleep problems. That can go with anxiety, it can go with depression, it can go with fear, and we're just seeing a lot of that. And people really need to kind of do short-term things to manage their sleep, use good sleep hygiene, because otherwise that can turn into some more serious problems. There's no question that I'm very worried about potential increases of rates of substance misuse. A lot of people are talking about the day was really stressful, I went home, I needed a drink. And one drink then could turn into 2 or 3 or other substances. And so while we don't have good rates on that at all right now, I think just anecdotally, we're certainly hearing about more substance use, and that could be quite problematic.
And then following up on the topic of research, is there any research that examines the importance of what is perceived by the public to be empathetic national leadership in time of crisis? Example, the fireside chairs of of the FDR during the Great Depression or Churchill during World War II?
So actually there is evidence from prior pandemics that what's effective leadership, empathic leadership, honest, transparent leadership, sort of a sense that we really care about you, we're taking care of you, is associated with people's having much better sort of sense of well-being, and whether that's national leadership or it's hospital level leadership, people feel less burned out, they feel less angry, less mistrustful, and more supported in the face of effective leadership. We know that from prior pandemics.
And then one of our viewers states the following: I am noticing that vigilance is starting to wane amongst my colleagues, a combination of fatigue and sense of inevitability. Any recommendations to combat this?
They noticed that what is starting to wane?
Vigilance.
Oh, yes. Yeah, there's no question that people are having quarantine fatigue and Zoom fatigue and all of these kinds of fatigue, as well as what I think of as mask rebellion. And it's very concerning. And I think this does fit with leadership in part, that the more we get clear messages and consistent messages about what we need to do to keep safe, it makes a difference. But, it's like you tell a kid or anybody to do a behavior differently for a while, and then they forget, and they need reminders. And they need reminders about, in a clear kind of way. And we're all kids at heart, and so if we don't get the reminders, it's problematic. And we know that those behaviors can certainly stem the virus. So I think that it's really behavior change that we need here, and we need to be very clear with our messaging about what we need. And we all need to not just listen to it, but I think I saw your question about if you see other people who aren't doing appropriate behaviors. I think we've all become complacent about that too. And we all have a responsibility not just to keep ourselves safe and healthy, but I know it takes courage sometimes, especially when there are power dynamics, but we need to speak to other people who aren't keeping themselves and therefore the rest of us healthy as well.
Thank you. I'm going to ask the participants to stick around for another 5 minutes. There are a few more questions that I'll try to ask both our speakers, if that's okay. And this will be recorded again for those who have to leave sharp at 4 p.m. Dr. Kaslow, one of our participants is asking about her daughter. Her daughter works at a high-stress environment, at a healthcare setting, takes care of COVID patients. She's asking, should she ask her about her day? At the end of the day, should she check in with her on that, or would that be a bad idea?
There's no right answer to that one for sure. What I would say is definitely check in and but make clear if you want to talk about it and you think it would be helpful, I'm here for you. And if you need a COVID break, I support that too. So I think it's sort of checking in, but making clear that either way to go is okay. And some days you may want to talk, and some days you may not want to talk.
And as a team leader, I know you've been doing work at Grady Hospital in Atlanta.
Mm-hmm.
Recommend some activities that can be done to mitigate these mental health stressors.
Yes, so there's a number of things that we can do as a team. So, one of the things I think about is if you have a huddle at the beginning of a team and sort of a huddle at the end of a shift, there are things we can do then. So, for example, at the beginning of a shift, some people are doing prayer circles or things like that. At the end of a shift, I'm really encouraging people to do gratitude, sort of take a minute and say what they're grateful for among their sort of team members and things like that. Maybe taking time out in the middle to do a mindfulness app together. It just takes a few minutes, or some teams are doing that at the huddle at the beginning. So I think one is sort of building that sense of team and things like that. I think another thing that team leaders are doing that really seems to make a difference, in addition to these sort of shout outs about positive things, is to create a calm place that people could go and get a break. Wearing N95s is really, really hot. It's causing people all sorts of difficulties in different ways. And having sort of calm places where you can go by yourself and just chill out for a bit, take your mask off, to be safe. That really helps. And then I think the final thing is back to that question from before. It's effective communication. It's listening, letting people know you hear them, using their ideas about how to solve problems to the best of sort of the ability of the system, and being very clear with people and engaging people in a collaborative way in handling every decision.
Thank you. That was wonderful. Thank you, Dr. Kaslow. Dr. Mead, I think we had a long enough break. I'm going to ask you a couple more questions before we wrap this up. The one question that came through regarding the UV light, role of UV light in disinfecting or sterilizing the filters. And then the second question that I'll ask you to comment on is the behavior if you're outdoors and then somebody's walking towards you that's not wearing a face covering. Should I be worried and try to move away from that person's path, or just in an outdoor setting in a park, for example? Would that be okay? So 2 questions for you.
Sure. Let's do the UV one first. So UV disinfection of filters while in place, I don't see any harm that can come from that. And this hasn't been researched, my intuition is that life on the surface of that filter is probably pretty torturous for the any captured virus. And so my gut feeling is that it's probably going to die on its own anyway. However, if somebody wanted to make darn sure that it was dead by adding UV, I would certainly not argue against it. I think the stronger role for UV actually is in upper room UV, which is a well-recognized effective technique for tuberculosis concerns. And has been, there's a CDC guidance document on how one might apply that. And it can be a very effective adjunct for certain scenarios where you want to disinfect aerosols or even droplets that are close to the source person. The second one, the outdoor, I've got to tell you, personally, I'm not overly concerned with most outdoor scenarios, unless perhaps you were in a really tightly packed concert or gaming event or something like that. The control ventilation, when we're designing engineering controls, control ventilation usually falls in the range of like 75 to 100 feet per minute. And so if we look at just a 1 mile per hour wind, that's 88 feet per minute. So the reality is outdoors, if we're lucky on a calm day, there's 5 mile per hour wind. So, you're looking at several hundred feet per minute that are capturing any generated aerosol or diluting them almost instantaneously and carrying them away. Add to that walking a few feet per minute at a time, and the really rapid disinfecting techniques we recently heard about from Homeland Security Science Directorate as far as direct sunlight. I just think there's a whole lot of protective things working in our favor when we're outdoors.
Thank you, Dr. Mead. Dr. Kaslow, one last question for you that just came in regarding any, can you recommend any virtual counseling resources for healthcare workers? And the other question regarding, what do you think about social networks, online social networks? Are they increasing anxiety and stress?
Lots of people's, am I on? Yeah.
Now you are. Yes.
Okay, sorry. I'm sorry. Online social networks, help some people and make other people feel worse. So I think you just have to pay attention or use somebody that they help. In terms of virtual support groups, I think that some systems have them, some countries have them. Most places have individual level, and you need to have somebody really develop the virtual support groups. We're doing a lot of ours virtually and some of them individually. You asked how to huddle on a Zoom meeting, and I think you just sort of mark it as a huddle. We're sort of in huddle now, and you take the time to kind of do what you would do in a huddle. Obviously, you can't stand closely together, but I think you can on Zoom sort of say, we're in huddle, and let's sort of take time to talk about what we need to talk about or what we're grateful for, and you can do that and mark time that way. And it's really, really important. And I've been encouraging groups to do that, and it's really been very helpful. I want to make one more comment. I know this is really sad, and I debating whether or not to share this, but while we were talking, I learned that a good friend of mine died from COVID. And I just want to say that this hits us all really personally. It's not just about people out there in the world or in our hospitals, it's people in our lives. And so the grief is very real.
Sorry for your loss, Dr. Kaslow. Again, on behalf of all of us today, we are sorry for your loss and want to make sure you know that in our thoughts with this tragic incident.
Thanks.
I would like to just give Dr. Wax the opportunity to close and maybe ask one or two questions, Dr. Mead. But again, I thank you all for listening. Dr. Wax, go ahead.
Yes, thank you very much. Yeah, Dr. Mead, two final questions. One is, are there measures that indoor businesses should institute as they reopen their businesses?
So I don't know that I would say should. There certainly are options they could consider doing so. In terms of how they operate in this new environment we find ourselves in, there's been a lot of guidance published in terms by both CDC NIOSH as well as by ASHRAE on this topic. But certainly things like it may not be the best time to try to minimize your outdoor air. You may want to try to increase your outdoor air. And it's also, there's something called, a lot of ventilation systems use something called variable air volume or demand controlled ventilation. And it might be a good time as we initially open up to deactivate and let those ventilation systems operate full time, full speed, as opposed to ramping up and down based on occupancy or perceived conditioning needs.
Okay, great. Thank you. And the final two questions. One of the listeners asked, New York City has some very old, tall buildings and projects. How efficient are the ventilation systems in some of these old buildings? Could the ventilation systems potentially have contributed to the high death toll in New York?
The honest answer is, without being and experiencing the exact situation that we're discussing about, it's kind of hard to say. That certainly crowded conditions and the exhaust of my building or my room is really close to an open window that it's immediately right adjacent to me. Maybe, as I said during my presentation, we haven't seen anything that showing anything like pathogens going through the HVAC system and landing up in a different area and still being infectious. We haven't seen any indication that that's occurring. So, the longer the distance you're talking about, the lower the likelihood that anything is being transmitted that way.
Okay, great. Thank you. And the final question comes from an educator. The question is, when providing an SVN treatment in a school, how long would it take to have the area safe for others who are not wearing a mask?
Okay, you're gonna have to help me on what an SVN treatment is.
Yeah, that's a nebulized treatment for asthma, commonly given by a school nurse, in an aerosol generating procedure, typically.
Yeah, if it's an aerosol generating procedure, if you don't have a reason to believe that the student has been exposed to COVID or anything like that, my apprehension level is probably less. That being said, if you can get added ventilation to the room, either with a portable fan or what have you, so the ventilation rate drives the answer to the equation, right? The other thing too is, if it's at all possible, if there's an outdoor picnic area and it's clinically appropriate to do so, could that treatment be applied outdoors? And that question's posed by me as somebody who really I don't have a full understanding of the clinical requirements. So.
Okay, well, thank you very much. So I'd like to, again, on behalf of Dr. Kazi, thank both of the speakers. Two very different topics today, but very important topics for all of us. And again, many thanks to both Dr. Kaslow and Dr. Mead. Next slide, please. Again, our resources are on the ACMT website. Questions can be delivered to info@acmt.net. Next slide. Our webinar for next Wednesday at the same time, 3 p.m. Eastern, will be a panel discussion on mitigating the intersection of COVID-19 and opioid use disorder. The directors of this session have brought together a very interesting and diverse panel, and it should make for a very lively discussion and a good Q&A on a very, very important topic. And that's, again, next Wednesday at 3 p.m. Eastern. Next slide. And the following week, on May 27th, we will be turning to a very important clinical issue of the pulmonary manifestations of COVID-19. As we've all learned, this virus is unlike any other virus known previously. The amount of new learning is at a frantic pace to understand exactly how this virus does its work. And we will be featuring several distinguished physicians who will be talking about the pulmonary manifestations. That's on Wednesday, May 27th at 3 p.m. Eastern. Next slide. And I'd like to, again, thank you very much for attending today, and have a good day.